For today, Wednesday, February 3rd. We do have a quorum, members, and today first on our agenda will be Senate File 475, Senator Draheim. Would you please move your bill and begin your presentation? Senator Draheim, you are muted.
Sorry about that.
Thank you, Senator
Thank you,
Draheim.
Chair. I would like to move Senate File 475.
Members, we have Senate File 475 in front of us. Please proceed, Senator Draheim.
I think first, to get the bill in the order, I have the A1 amendment.
Senator Draheim moves the A1 amendment. I'm going to ask everybody to turn on their video and their microphone. This is an author's amendment. And those who are unable to join us by video, please turn on your microphone. All those in favor say aye.
Aye.
Aye. Any opposed? Thank you, members. Senator Draheim, your amendment is adopted.
Thank you, Chair Benson. And what we have today here is a kind of a solution to a problem of our one part of a problem is we have our healthcare workers are overworked. Dr. Klein, you have mentioned that in the past, and last week the White House put out a call for more people in healthcare to help with the vaccine effort. And the dentist came to me a while ago about them being able to administer the vaccine. And they can do the flu shot right now, which I don't think everybody understands. And of course, they give other pain meds and Novocaine, et cetera. They are trained for this, and they would still have to go through whatever training is required by the state to administer this vaccine. So they would be treated like everybody else to do that. But if the vaccine becomes more prevalent and a larger supply comes into Minnesota, we're going to need all hands on deck to get this out as fast as possible. So I view this as just a common sense solution to help out in the vaccine effort. And with that, Chair, I think we'll go to testifiers and then I can answer questions later.
Thank you, Senator Draheim. And first on my list is Dr. Jim Nickman with the Minnesota Dental Association. Welcome to the committee. Please unmute and video, state your name for the record, and proceed.
Thank you. My name is Jim Nickman. Madam Chair and Senator Draheim, thank you for having me today and for hearing this bill. My name is Dr. Jim Nickman. I am a pediatric dentist in the Twin Cities and currently president of the Minnesota Dental Association. I am also the past president of the American Academy of Pediatric Dentistry. Throughout the pandemic, dentists have done their part to help minimize the spread of COVID-19. Many clinics donated PPE in the first month of the pandemic. We kept our doors open to provide emergency care and helped to keep people out of the emergency room. We have implemented safety protocols in our office to minimize the spread, and now we want to continue to help our communities and our patients by administering the COVID-19 vaccine. Dentists are highly trained healthcare providers who frequently give injections to our patients. Due to the nature of the work that the dentists perform, we are trained to give simple and complex injections to administer medications such as anesthetic and others. Dentists are also part of the healthcare system, and we want to do our part to help keep people safe and healthy. We believe that dentists could be part of a larger provider workforce that could help administer vaccine in community settings. I also believe that dentists could help with ongoing efforts to annually vaccinate Minnesotans with a regular dental visit. Dentists can also play a critical role in vaccinating Minnesotans in the rural parts of the state where they live, and to help limit the travel time to get vaccinated. We have heard from dentists who want to help, and we urge you to support to allow them to do their part and help put COVID-19 behind us. Thank you again for your time.
Thank you. I also have, I believe, Dr. I believe Chris Earsman is with us for a comment from the Department of Health. And
Yes, Chair Benson, I am here. I just wanted to say that we are grateful for the amendment to include eligible in the definition of providing vaccine to eligible individuals. And we support efforts to expand qualified practitioners to be able to help us provide vaccines as the supply increases. And Dr. Nickman, my dad, was the president of MDA, Jerry Rosedal, a number of years ago. So I understand that dentists are good eggs. So thank you.
Thank you very much. Let's see, let's go to member questions. Senator Klein.
Thank you, Chair, and thank you, Senator Draheim, for offering this bill. It's the second time I've sat across the table from Senator Draheim today, and I've appreciated both the bills he brought forward, the Taxes Committee as well. The A1 wasn't explained, and I wonder if either Senator Draheim or possibly Ms. Kavanaugh could explain if there's I thought it was just sort of a cleanup of language, but it sounds like there's an actual substantive change. And then I have a follow-up question.
Senator Draheim, we treated it as an author's amendment. There were good reasons for the changes. It wasn't just cleanup. Would you like to explain it, or should I have Ms. Kavanaugh?
I think she'd probably do a better job, but it was from stakeholders, Senator Klein, that we took this MDH and others that, trying to get everybody to buy into it and to clarify it a little bit. But if she wants to go through it, that would be wonderful.
Ms. Kavanaugh.
Yeah, Madam Chair and Senator Klein, there really isn't any difference substantively other than the addition to eligible patients on line 1.9 that the Department of Health mentioned. Otherwise, it really is just using the House language so they match up better, and it's changing things like instead of immunization, we use vaccine and that sort of thing, and just different terminology that really doesn't change the substance of the bill.
Senator Klein.
Thank you, Chair, and thank you, Ms. Kavanaugh and Senator Draheim. Again, just thanks to the authors. We need all hands on deck as this thing goes forward. Dentists are obviously a great resource and colleague in this project, so good on you. Looks like 20 states, I'm being told, have already sort of passed legislation allowing this. And I also noticed in looking through the language of the bill that you've expanded sort of the age range for dentists to administer the influenza vaccine, and I obviously support that as well as a pretty reasonable public health measure. So thank you for getting this in. Senator Benson, is the plan to move this to the floor today?
The motion would be to the floor. I just need to check with the Board of Dentistry to verify there's no fiscal note. I didn't anticipate there would be any fiscal implications. So the only place I could see that there is a cost because of the training, but we do have MDH here, and they have a standardized training for these vaccines that they've been using. If Ms. Earsman could speak to that the training is free and available, not free. It is not a cost to the vaccinators. It is handled by MDH on some of our federal funds.
Yes, Chair Benson, we do have a training. We have a provider guide on our website. We have just-in-time trainings, and we have a team that's available for consultation. And so, yes, there would not be a cost to the vaccinator. And you're right, we do have to pay these staff, but it is part of our program and it is covered. So no cost to the dentist for getting that training.
Okay, thank you. I'm not seeing any further hands raised. And with that, Senator Draheim, closing comments and prepare to move your bill, please.
Thank you, Chair Benson, and thanks for your help pushing forward this and all the support, Dr. Klein, and the agencies. And I think this is just another group of people wanting to be part of the solution. I thank all the dentists out there that want to help out. And like Dr. Klein said, that there's 20 other states that have already done this. There's 10 more in the hopper. So let's be part of the solution and move forward. So thank you, everyone.
Thank you. And Senator Draheim, right now we have more people who want to vaccinate than we have vaccine to roll out, but I don't anticipate it will be very long before we'll have a good amount of vaccine and will need dentists in their local communities, taking care of the people they take care of every day. So with that, members, Senator Draheim renews his motion that Senate File 475 as amended be recommended to pass and placed on general orders. I'm going to ask you to turn on your video, unmute your microphone. And I see a couple folks getting ready to join us here. All right. All those in favor signify aye.
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 Any opposed? Okay. Thank you, Senator Draheim. Senate 475 is on its way to the floor. Thank you, members. Our next presentation, MDH is getting another tranche of federal funds, and it is our responsibility to review the operations at MDH, see how they interact with the ongoing operations, but also there's going to be an LAC request. And so I thought this would be a good opportunity for the public to see and members here to see what the LAC will be seeing. That's a lot of C's, members. And with that, I believe we're going to have Commissioner Kelly and Joshua Bunker, who's the CFO. And so if they could begin the presentation. Welcome to the committee, and please proceed.
Thank you, Madam Chair and members of the committee. We, as Senator Benson said, want to walk you through some of our anticipated budgets for both vaccination and testing, COVID testing, as we look towards the coming in the next calendar year, the calendar year we're in. We have $325 million from the federal government for testing. And we have $51 million from the federal government for vaccination efforts. We have also been authorized by FEMA for 100% reimbursement for FEMA eligible activities towards vaccinations. So we are also working to identify what activities in our budget we could apply for FEMA reimbursement for. And that just came down yesterday. We're still doing that work. The point I'm trying to make here is that this is a moving target. And the sooner we have the authority to spend federal funds, the sooner we can start using those funds as opposed to COVID-19 Minnesota funds, which are general fund dollars. And our goal will be to draw down every federal dollar we can and use it, and save any general fund resources for the end when we may be running out of federal resources. With that, we've put together a slide deck that helps you to see what our best guess at this point in time is around testing and vaccination, what we think we'll need, how much we have, and how we're using available resources for that. But also to answer some questions the chair had about how we've used previous funding for contracts to stand up our vaccine effort and our testing effort. And with that, I'll turn it over to Joshua Bunker to start walking through some of these slides.
Good afternoon, Madam Chair and Committee. Joshua Bunker, CFO at Health. Next slide, please, Lisa. We will talk both about the $51 million for vaccination and then the $325 million for testing, and then move on to the historic review. In front of you, members, is our present plan. And this plan is just about 3 weeks old now, just into the first week of February, as we are ramping up to deal with the challenge at hand regarding vaccination. You will see, as we have presented in other testimony before this committee, a similar presentation of action items and areas of spending along the left-hand side of the page and across the top horizontally are funding sources. You will see, and I apologize, it is slightly cut off at the bottom of the page or the presentation, a budget in the neighborhood of $168 million, and that is at the very bottom of the projected need category. Sorry for some sizing challenges here. The grant that we're looking at discussing right now, the $51 million, is the column directly to the right of the projected need column. That's the $51 million of federal. I'll spend a moment of time as well going over the COVID-19 Minnesota funds and FEMA in just a moment. Those federal vaccination monies are the ones that we hope will be coming online in the neighborhood of 2 weeks, and then being able to point expenses in that direction. At present, we have that distributed approximately half to tribal, local public health and healthcare coalitions, paying for staffing that would actually do the vaccination itself, equipment and site costs, lease, rental, those types of things, a bit of IT, then work as well on a larger immunization platform that is being developed right now with Minute, so others are able to register with the randomization capability that has been discussed, I believe, earlier, embedded within that system, communication around the vaccination effort, and then work into the communities. We did speak as well about the warehouse leasing costs. Madam Chair, I just want to acknowledge that we have had ongoing conversations about that. We could go into more detail on that. I believe you have a handout, or I could continue on toward the COVID-19 Minnesota monies.
Thank you, Mr. Bunker. I did get a little more detail on the estimated cost for the warehouse. I appreciate that. If you have that information, I believe we can make it available to the committee. There is something that I did notice. Reassigned MDH staff appears both here and then further down the line, MDH staff, Vax hotline, et cetera. When MDH staff is reassigned, are there salaries that are now picked up by federal money? Does that drop to the bottom line, and will we see that as a benefit to the general fund?
Madam Chair and members, the question of funding has to do with where those redeployed staff were working prior to moving over to an assignment in the warehouse. And so I would have to look at the specific detail of those staff who were reassigned, and then we would determine whether or not it would be offsetting a state funding source versus a different federal funding source, or these could be staff who are working in a different project within the response, but we can follow up on that.
And for the committee and those watching, if staff was funded by a federal grant, we wouldn't expect to see it fall to the bottom line. Or if they were working on a grant out of Healthcare Access Fund, we'd see it show up there. But it's something we need to be aware of, that every time we see MDH staff being moved around, they're not doing some other job that was in our budget. Not to question whether this is more important than the other function, but we need to be aware that as we approach the budget, there's going to be some money cascading out, and we just need to watch for it. Please continue. I'll make sure the committee gets the warehouse cost spreadsheet, and you can continue on this slide.
Madam Chair, thank you. The column to the right of the $50.9 million is a combination of base grant to the department in these areas plus 2 small supplemental awards. You see how those are distributed. Those are CDC grants as well. Then just for a moment, the COVID-19 Minnesota money is just under $40 million. These are the state monies that we anticipate being able to offset by FEMA incoming monies soon. We did request on Friday $30 million from FEMA toward expenses that we're estimating over the first 90 days of the response that could fall into this state-funded category. We received on Monday into the state $15 million cash, the fastest FEMA turnaround I think any of us have seen. As we begin to change the way in which contracts are structured or items are paid, we know that immediately we will have $15 million of the $40 million that will be available to offset the COVID-19 Minnesota amounts and free up those state dollars. As we continue forward within that full 3-month window of the $30 million estimate, as invoices come in and we're able to pay those off, then we will submit to FEMA the amounts above $15 million, receive those monies back from FEMA, and then offset again, this $40 million amount to the extent that it's possible. FEMA has not closed the door in saying that it's 90 days and that is the end of our ability to submit. However, we were asked to submit in different FEMA projects in kind of summaries of different expenses. And so we anticipate in a little while that we will have the opportunity to submit for additional amounts. Now, the restriction for us on FEMA dollars is that FEMA dollars cannot offset other federal amounts. And so we'll be focusing most closely on any and all state funding that we have at present pointed toward vaccination efforts or would bring to bear later in this response to see what the total amount of FEMA reimbursement we can receive. And as Deputy Commissioner Kelly said, FEMA has said 100% of funds, and so we will look to rearrange and reorganize our expenses so that we can move the greatest dollar amount into state funding areas as soon as possible, and then submit to FEMA to receive those dollars back.
Thank you. Mr. Bunker, Senator Rosen does have a question. Senator Rosen?
Yeah, thank you, Madam Chair. Mr. Bunker, as the chair knows this too, and correct me if I'm wrong, any leftover money from the COVID-19 fund would have gone to the general fund. So this is the reimbursement that's coming back from the feds is going back to be used for COVID and not the general fund. Is that correct?
Mr. Bunker?
Madam Chair, Senator Rosen, my understanding is that the FEMA reimbursement will reimburse to the COVID-19 Minnesota Fund, and then the COVID-19 Minnesota Fund would be able to be canceled back to the general fund.
Senator Rosen?
Madam Chair, is that how we have understood that in the past? I understood it in finance that it would be able to be used once again to maximize more dollars for COVID, and the general fund would not be replenished or something.
Madam Chair and Senator Rosen,
Commissioner Kelly?
we've had about 24 hours with this FEMA announcement, so we will connect with MMB and get back to you.
Thank you, Madam Chair. Yeah, I think that's a really important.
Senator Rosen, the COVID-19 fund, if the money wasn't encumbered, expended, there are a whole bunch of, we've got issues to work on there by December 31st. Then I think it canceled to the general fund. And so I don't want to mischaracterize, but my understanding would be that if this money that had been a planned expenditure is then backfilled with federal money, it would go to the COVID-19 fund and then should cancel. But let's follow Commissioner Kelly's lead here and get an M&B answer in short order. So it would be nice to, we're never going to have certainty, but let's just be clear about what we can be clear about.
Thank you, Madam Chair, and I appreciate that. There is that. We've had this discussion in finance. I'm just looking for the 200 million that we gave, to the COVID Minnesota Fund.
You and me both. Senator Curran.
Thank you, Madam Chair. Mr. Bunker, could you cover the IT costs? Just give what's all covered in that 3.5 forecasted need? Is it software licensing? If so, what is it or are we purchasing, or are we developing IT solutions for this particular segment where we're in?
Madam Chair, Senator Curran, we actually will have some detail in a number of slides on this, but it is a combination of software licensing, expansion and build through Minute, and then connecting through other online systems to be able to organize and place some structure, certainly from the IT side around this response.
Thank you, Mr. Bunker. I look forward to the details following.
Okay. Thank you, Mr. Bunker. And we're still continuing down this slide. I think I interrupted your presentation.
Madam Chair, thank you very much. So again, with the COVID-19 Minnesota funds, that is one of the other areas of funding. Moving to the right, we anticipate using $20 million from an earlier $133 million grant from the CDC toward vaccination work at local and tribal public health, healthcare coalitions. Then a small amount in the second to the right column for community vaccinators in long-term care settings. These would be monies that we're carrying over from last calendar year, where we believe there's a dual purpose to be most efficient with those monies. The remaining need column on the far right is just our present plan and understanding of resources available to accomplish this work. While it is showing in the neighborhood of $48 million short, we acknowledge that we are both just starting in and the fact that we anticipate that additional monies will come from the federal level for the state. We don't understand at this time when or how much. We certainly are looking for those monies to come. But that would be the context in which the $51 million federal award for vaccination would fit at this time in plans from January through December.
And Mr. Bunker, Senator Draheim does have a question. So Senator Draheim.
Thank you, Chair Benson. Kind of going off of Senator Cran's question about the IT costs, the registry underneath that, can you, and then just expand on what that is being used for is my first question. And then I have a follow-up if I could, Chair.
Mr. Bunker.
Madam Chair, Senator Draheim, actually, I'm going to ask if Deputy Commissioner Kelly would be able to fill in on this item.
Commissioner Kelly.
Sure. Madam Chair and Senator Draheim, what we are trying to accomplish here is kind of a portal or a registry, a wait list, a place, a landing place on our webpage where you could go and you could type in your name and you could type in the information we would need about you to identify which priority group you would fall into. Do you work in education? Do you work in the food sector or grocery store? Are you a first responder? Those sorts of questions that correspond with the prioritization within 1A, 1B, 1C categories and 2A, B, and C. And then and asking the questions, do you want to be notified by a vaccine partner of availability for appointments? So that you could type in this information, you could then find out where you fall in the prioritization. So me, Margaret Kelly, not being over 65, not having an underlying health condition, not being in one of the critical sectors, I'm going to wait until the end of the line to get a vaccine so that people know where are they in the lineup. But then also being able to say, will you let me know when you get to the last person in line so I know where to go to get a vaccine? So you can say I'm a first responder and I want to know when you open it up to that group and who the vaccinators will be. That's what we're trying to get to with the immunization registry. We have it in here falling to a couple different pots of funding. What we are learning right now and with this FEMA reimbursement is that we can actually request 50% of the cost of this registry upfront, and FEMA will provide it right away. And then we can seek the remaining reimbursement once the funds have been spent. And so some of these things which we have budgeted may actually be fully reimbursed through FEMA, and we won't actually see them hitting the budgets. We'll just be using these budgets for cash flow. But I hope that answers your question about the immunization registry. The IT costs, which we'll see in more detail, are some of the technical contracts that we need behind the work we're doing in order to set up a call center. There's some technology behind that in order to make sure calls don't get dropped. In order to have So there's just a lot of technology that's holding up a lot of our work, and that's some of the buckets of IT costs that we're looking at.
Chair Benson?
Senator Draheim, further questions?
Yeah, so just for clarifying, that registry then, that cost there is for call center or for technology, or what is that? And then I would like some more definition on the community coordinators too, please.
Madam Chair and Senator
Commissioner
Draheim,
Kelly.
the registry is for the technology of being able to put it out there on our website that people can interact. The call center would be a separate line, and I'm not sure where that's showing up in this budget. I think it's under the VAX hotline and nurse triage line, perhaps. And that is just, there's a technology piece to that. There's also a staffing cost piece to that. And whether we contract out for that or use MDH staff, we're looking at how we can leverage our multiple call lines right now with our public hotline and our provider hotline, and the likely need to have a hotline for people who are struggling to figure out the registry as well, so that we can get them the help they need when they're trying to put their information in. And I'm forgetting the other question you had. I'm sorry.
Senator Draheim.
Thank you, Chair. Assistant Commissioner, it was on the community coordinators.
Oh, sure. So
Commissioner
we, Madam Chair and Senator Draheim, we have, through the lessons learned from our testing strategy, one of the things that we found of enormous benefit in our testing strategy, we funded some community organizations to help us with our testing strategy of communicating with people in the community, letting them know what we're trying to accomplish with testing, what testing meant, when you should use testing, where you can go to get testing, and actually staffing some of our sites to help people navigate the testing event. And that has been enormously helpful in ensuring that there was good access to COVID testing in all of our communities. And we are bringing that lesson learned into the vaccine realm here, especially with the hesitancy that there may be in many communities to get a vaccine. And so we are going to be leveraging that organizational structure that we built, that network that we built with COVID testing, to help us with vaccination.
Thank you.
Senator Draheim, any further questions?
No, thank you both.
Thank you. Senator Rosen, I believe you were next, and then Senator Nelson.
Thank you, Madam Chair. Yes, thank you. I had a question on the community vaccinators and their contracts, how that works, who is a community vaccinator, the training that they go through. I would assume this cost of $19 million includes that training to vaccinate. And another question back to Senator Draheim's bill with the dentist, and that there's going to be some training or some training that's the dentists are not going to have to pay for, but there will be some training. This is all COVID reimbursed. Is that correct? And that will show up. So it's a two-part question, basically. How long is these contracts with the vaccinators? Who are they? And does this training that you are going to be providing, can that be reimbursed by COVID dollars?
Commissioner Kelly.
Thank you, Madam Chair and Senator Rosen. So this envisions contracting with healthcare organizations, or, in COVID testing, we have used like Homeland Health. We have used an organization called Bluestone that provides nurses or other healthcare professionals who can actually do a COVID test. And so we would use similar types of organizations who can actually give a vaccination to an individual that we would then deploy out in the community as we have more vaccine. And and as we are trying to ramp up the administration of the vaccine as quickly as possible. And so it encompasses all the training that would be needed, and definitely to the extent that there may be a cost for training within Senator Draheim's bill, we certainly could use this funding to cover that.
So, Madam Chair,
Senator Rosen?
so these contracts, how long are these contracts with these organizations that you mentioned? And would they be being paid the same amount as a pharmacy would be paid? I would assume a pharmacy would be paid to give the vaccination. Is that correct?
Commissioner Kelly.
Madam Chair and Senator Rosen, so we are not contracting with pharmacies to give vaccinations. Pharmacies are registering with us to be a provider, and there is no cost to them to be a provider. We are giving them vaccine, and then they are working with healthcare to figure out how they get reimbursed for that. These are community vaccinators would be the contracts. I don't know if we have any contracts set up yet, or if they're in the works. I don't have an answer for that. But it would be for people that we would want to actually go and give shots in addition to, pharmacies. This assumes that at some point of time, we're going to maximize the capacity of our pharmacies. We're going to maximize the capacity of local public health and healthcare systems, and we're still going to have doses that we want to push out when vaccines are flowing much more freely than they are now.
So, Madam Chair,
Commissioner, I almost called you Commissioner Rosen, Senator Rosen.
call me whatever you want. Ms. Kelly, I am concerned that we've got 19 million here. We don't know what the contract is, how long the contract is, how much is being paid for a network of vaccinators that I don't know where they're going into, that perhaps we already have a system of pharmacies and dentists and whoever else can give these vaccinations, that we're paying for these unnecessarily. I feel like there's more information that needs to be pulled out of this, Ms. Kelly. And if you could do that and tell us exactly what's happening with this 19 million, I would appreciate it, because I have more questions now before my original question, than the answers were provided. So thank you.
Commissioner Kelly, any comments?
No, I'm happy to try and clarify that for you, but I'll need to come back.
And just to kind of close the loop, and Commissioner Kelly, please correct me, MDH, the federal government is paying for vaccine at this point. So the question of the cost of the place where it's reimbursed and the personnel to put it in the arm, hospitals can ask for insurance reimbursement. Pharmacies can ask for insurance reimbursement. But when we're in the community and we're not asking for insurance, we need to pay for the building, we need to pay for the people, and then the training that goes with that. And so I just want people to understand that the vaccine is being paid for by the feds. Administration is going to be paid for in multiple ways, and the feds have given us the money to do that. But there's also insurance that is paying for some of these vaccines. So Senator Nelson was next for question.
Thank you, Madam Chair. My question is a bit on the similar lines, but it's a bit more of a broader question. I'm trying to understand the intended audience for this particular vaccination funding plan with these CDC dollars. My experience with my constituents is that they feel much more comfortable seeing a trusted healthcare provider, pharmacist, now perhaps Senator Draheim's bill goes through, their dentist, knowing that those healthcare providers know them best. But this idea, so this kind of looks, so how do you maximize use of our, and I think Senator Rosen kind of mentioned this in a sense too, our existing structure, which includes those medical professionals that our constituents, many already have relationships with. And I'm thinking about experience of the last couple weeks with the test pilot sites. We learned right away that having a lottery and a sign up obviously doesn't work. And then we learned the next week that having people register at a certain time for a particular, I guess the first was first come, first serve. That doesn't work with prioritization. The second week was kind of the sign up for the registry, and then there'll be a lottery. And so clearly none of that really speaks to doing that prioritization of getting limited supplies into the arms to protect those who are most vulnerable, yet the medical providers do know that. And so what I want to know is, how does this plan for about $51 million of CDC grants, how does this interact with vaccines that are being distributed to local providers who are able to serve their patients and prioritize and that type of thing? So what's the interaction here between this, which seems like kind of a mass vaccination, as opposed to maybe it's kind of like those test sites, as opposed to using our healthcare providers and our infrastructure and those relationships that are already in place?
Commissioner?
Madam Chair and Senator Nelson, I appreciate the question, because it gives me an opportunity to help explain the whole ecosystem of our vaccination partners. And what you're seeing here is just a sliver of the pie, that the total need for this MDH's responsibility for figuring out how to vaccinate 5.6 million people in a matter of a couple of weeks is what it feels like. That we think our costs are going to be in the $160, $170 million range. And that we're going to leverage as much FEMA money, we're going to leverage as much federal dollars as we get. And with this, the grant that the federal government has pushed down, the $50.9 million, that we think this is how we'll use that grant to plug to support the $167 million of need. But in terms of should we be doing these mass vaccination sites, or should we be using these resources to fund our current infrastructure? We need to be doing all of it. And our current infrastructure has the capacity to do 200 to 300 to 400,000 vaccines a week. We are using that current infrastructure. And you're hearing from a lot of people saying, I don't know how to get to a vaccine because we don't have enough vaccine yet for everybody to access. What we've learned so far, and we're trying to listen closely and pivot what we are doing based on feedback we're getting and what we are hearing is working and isn't working. But there are some people that appreciate the state sites and the opportunity to get into a lottery to get a vaccine. There are other people that it's not working for them. But we are pushing out vaccine to our healthcare system as well. This is not the only game in town. And so we are leveraging as Commissioner Malcolm, if she were here, she would talk about the ecosystem of our vaccinators. We have local public health who can provide vaccines within their community. They're focusing on the healthcare 1A population, but they're also expanding into 65 plus and educators, the whole eligible population. We have our big healthcare systems. We have small, mid-sized hospitals and community clinics and independent, unaffiliated clinics and federally qualified healthcare centers that all have a patient provider relationship and that many people prefer to go to get their vaccine. And we are pushing doses out to them as well. We are not needing to fund that infrastructure in this budget. And that's why you don't see it here and why it may feel lopsided to you. But we are using that infrastructure and pushing doses out that way. We are also trying to ensure that, I'm forgetting, pharmacies, that is a place where people often go for their flu vaccine, and we envision that they will also go there for their COVID-19 vaccine. And the federal government announced yesterday, another thing, 24 hours news that we're still trying to figure out, a federal retail pharmacy program, which will, at the federal level, push doses into the state of Minnesota through selected pharmacies that the federal government has contracted with, and that those pharmacies then will create opportunities for people to call and schedule an appointment to come and get a vaccine. So there is going to be a variety of ways, and I know the multiplicity of avenues to get a vaccine creates confusion, but it is, especially at a time of scarce resource. But we are trying to ensure that we can use every possible dose as quickly as possible so we get to maximize the number of people who have been vaccinated, and because every vaccination protects other people and especially protects our most vulnerable. Through our federal, I'm sorry.
Senator Nelson.
Oh, thank you. I did not mean to interrupt, Commissioner. I do have a follow-up when you're finished your comments.
Sure.
I didn't mean to jump in on you.
Yeah, I was just going to add, when you get a flu vaccine, you could go to your pharmacy, you could go to your healthcare provider. It could be that there's a flu clinic that comes to your workplace. So we have been envisioning we would use all of those avenues with COVID-19 vaccine as well. It just, when we get flu vaccine, we get all we need for the entire season on day one, and we can push it out, and nobody needs to worry about whether they can get a shot or not. With COVID-19 vaccine, we are just getting it drop by drop, and so it seems more chaotic for that reason, but we are trying to leverage the whole vaccination ecosystem in the way we typically do. And we're trying to add to that so that we can ensure people can get quick access to doses.
Thank you.
Senator Nelson, anything further?
Yes, thank you, Madam Chair, and thank you, Commissioner. So who makes that decision? If you don't mind, just this little rabbit trail, I think it's pretty important though. Who makes that decision about how much of the limited supply that we have of vaccine goes to those existing infrastructures that already have relationships with Minnesotans, their patients, the trust, all of that communication is there. Who makes that decision about how much of our limited supply goes to that existing infrastructure and how much goes to kind of this new mass vaccination, these mass vaccination sites?
Thank you, Madam Chair and Senator. We work through those decisions within the Department of Health every week. We call all of our vaccine partners to say, how much could you use? Do you have clinics that you're planning? What is it that you need? How quickly can you get it out? Can you meet the metrics? What populations are you serving? And we compare that to who the eligible categories are and what the available doses are. One of the challenges that we're facing is that this particular vaccine is fragile, and it comes in boxes of either 975 doses or 100 doses, depending on the product that you're using. And it needs to be stored in certain conditions. And once opened, it needs to be administered within a set period of time. And the boxes can't be transported from one facility to another repeatedly. And so these are all the types of constraints that we are trying to balance in our allocation process on a weekly basis. There will always, until we have enough vaccine for everyone, similar to the flu vaccine, we will always have providers who could administer more, and we don't have enough doses to give them.
And then just a follow-up comment to end.
Senator Nelson.
Thank you so much. Well, Commissioner, I definitely understand all hands on deck. I definitely understand the scarcity of the vaccine. My suggestion would be, or comments that, and just from the experience that I see in my district and with constituents, and actually not just my district, my email in general, hearing from Minnesotans across the state, it seems to me that we should maximize those existing resources, those relationships now that are best able to prioritize let's make the maximum use of what we have right now. And then, of course, are we using the National Guard? I mean, they are experts in logistics. And then with those logistics of making sure that doses get used in a certain amount of time, they have the correct temperature control. So number one, can we maximize those existing relationships with healthcare providers, pharmacists, get more people vaccinated in ways that they know where to go, they know who to call, and those people can prioritize according to need. And then also use the National Guard in logistics, which is really getting needed supplies to critical places at critical times. And are we doing both of those things?
Commissioner Kelly.
Madam Chair and Senator Nelson, we're doing our best to leverage the existing infrastructure, and we are calling on the Guard when needed. And so, yes, it's not necessarily, we don't necessarily need the National Guard to drive vaccine from one place to another. It is shipped directly to the provider from the federal government. And so there isn't the logistical transportation issues that I think some people imagine there being. It's direct shipped to the provider. We have used the Guard on several occasions in the past number of weeks to help us with vaccine administration. So we're leveraging them. We are pushing vaccine out to our providers as there are small unaffiliated clinics, unaffiliated to a larger healthcare system that have not yet gotten doses. We try to prioritize them as well so that we're sure the population of individuals that access their provider to get their vaccine are getting equal access to that as well. So it's a complicated balancing act.
Thank you, Senator Nelson. And Commissioner Kelly, I know that we have experts across the state of Minnesota who are ready to help. I know that the National Guard has been called on to move vaccine if a hospital had excess. That was several weeks ago. I cannot stress enough, there are Minnesotans who want to help. And we saw that with the pharmacists. Now we're seeing that with the dentists. I know that the healthcare systems had to work really hard to get a place at the table. I hope that we get better at using what we have in place already. If we're drop shipping vaccine, then what are we doing with the warehouses?
Madam Chair, good question. The warehouse is being used for things right now like PPE. We are still shipping PPE out to long-term care and primarily long-term care. It's also being used for supporting the state vaccination clinics with the supplies that are needed there around syringes or other PPE for those events. It is also being used for testing, for the supplies needed around testing and receiving and shipping out testing supplies. So it's not actually being used for the vaccine product itself.
And thank you, because there was some claim that we were going to use the morgue for that, and that's not the case. All right, we need to keep moving. Thank you, Mr. Bunker, and I have so many questions, but folks, this is what an LCRC here meeting sometimes looks like. So, Mr. Bunker.
Thank you. I believe at this point, say next slide. We referred to a little earlier that there was a list of technology in both providers, systems, and enablements connected to our technology systems and build-outs to accomplish this task of organization, prioritization, randomization, logging, all the items that Commissioner Kelly spoke of earlier. This is the list in front of you of providers of scheduling, contracting, managing hotline, staffing hotline in addition to MDH staff, and then just a selection of other IT add-ons or creations by minute to enable us to respond appropriately. I don't know about other questions that you, Madam Chair, others may have, but these are, again, those lists of contractors and systems that have been appended to the vaccination effort.
Thank you. And I'm not seeing any hands, Mr. Bunker. Senator Coran can follow up if he has any questions. Let's continue.
Thank you, Madam Chair. Next slide, please. Just at a glance, wanted to show, as much as we are so very focused on vaccination right now, certainly testing efforts are continuing. This is a timeline of activity that has happened from the very beginning of our response in terms of numbers of tests by week on through present, which shows up kind of in the middle of this slide. You will see in the gray long-term care and activities for testing that were done by mail and you as we move forward, and now are more focused on long-term care and other settings like some bits of corrections as well as fault. And then we move into the community testing amounts, and you see really a peak leading up to and just after Thanksgiving for test processing. And as we're moving into now this new calendar year, you see the addition of K-12 and childcare tests. The initiative is a back-to-school initiative. These testing amounts moving forward are projections that will feed into the budget sheet that we have on the next slide. So these are actual testing rates through present, and then projections.
Okay, thank you.
Next slide, please. This slide is laid out in the same way that we discussed the vaccine efforts. We're highlighting on this slide the $325 million CDC award into the state for testing and testing related activities. Along the left side, you see the three major areas at present of lab processing, starting at the top around the K-12 and the community testing and the long-term care that were on the prior slide that we referred to. Mm-hmm. You see long-term care staffing for being able to support the facilities and then administer testing. The mobile testing and testing supplies is primarily pointed toward the community testing events, for the stand-up events, the equipment, materials, logistics needed for those. Testing team staffing is primarily the State Emergency Operations Center, which includes leads for the various areas, in this case testing, plus other deployed staff, MDH staffing that is required for the wraparound testing effort. Media and diverse testing related. This would be communication, messaging out in the community, the Safe Minnesota campaign, continuing those costs. Unique minute costs again. Again here, both budgeted and anticipated. Case investigation and intake certainly is a large area. These are the activities that are required to follow up on the positives and then enter information into state systems for tracking progress. Warehouse information, budget here. And then the last line before the total line are the non-testing grant requirements for these CDC awards that are not to be used, according to CDC mandate, solely on testing costs. And so these costs are for strengthening the public health system, enhancing lab ability to do genome testing, other things that are happening now with some of the variants, improving surveillance capabilities across the public health system, and supporting public health. And so as an example, there was a $20 million item on the vaccination budget a couple slides ago. Those $20 million were funded out of the second to right column of the 2020 CDC $133 million item. And so these monies can be moved slightly for some different purposes, but CDC does review our work plans in these areas and ensure that we have the required performance goals and metrics along the way. So specifically on the $325 million award, you see how that is broken down and applied to the right around $586 million of total costs. This budget has a projected shortfall of cash at this time of $73 million. The line of estimated insurance reimbursement from Mayo and the U of M is showing our anticipated insurance returns back from Mayo and the U as they would bill insurance providers. Those monies then would come back and be able to be applied to all the testing efforts in the state and offset that shortfall by the $61 million, resulting in a $12 million projected shortfall at the moment. That $61 million is dependent upon the number of tests in a particular area, the ability to leverage those insurance reimbursements, and that is our best projection number at the time as we continue to move forward in the next months and better understand the percentage of insurance collected in different areas and the billing that happens in our different areas. We will see the performance of that number as we move through the slide. I don't know if there'd be any other need to go through detail on that 325. I certainly can.
If we could go back to the previous slide. So members, we also have a slide of things that have already been done or are supposed to have been done. I'd like to draw your attention right now to the no bid contracts that are included on this slide. And Commissioner Kelly, could you help me understand the vault contract that was executed without legislative approval for 24.6 million, not to exceed. That was with vault as well, and that includes $4.7 million of the purchase and installation of laboratory equipment. And now we're spending more money with vault. I see there was just a significant hire to lead the vault efforts nationwide from Minnesota. So members, we're going to need to pull some stuff out of here, but one of the math problems that I'm having is our estimated insurance reimbursement is 61 million, but look at how much we're spending of this federal money on lab processing and testing. And so Commissioner Kelly, I know we're going to do surveyed testing. You and I talked about this on Sunday night. This goes January through December. So we need to start wrapping our heads around the fact that this is the plan from now through December as we're rolling out the vaccine. So Commissioner Kelly, could you walk us through why, particularly in K-12 schools, community testing, we're getting such low reimbursement, low insurance reimbursement?
There you go.
Thank you.
Thank you, Madam Chair. So we have several ways we have contracted for testing. We have negotiated a rate with Mayo and the U of M, and we are paying them in advance, and they do the testing and they seek insurance reimbursement. Or let me go back. We pay them in advance. They do the testing. They tell us how much they have done. They seek insurance reimbursement, and when they receive it, they send that back to us. And we net that out against the cost of the advancement to the U and to Mayo. With our community testing, we have negotiated a different payment methodology where we are reimbursing that provider for the testing that they do. So they are cash flowing the state, and they conduct the test. They bill the insurance. We have agreed on a rate that the state will pay. They conduct the test, they bill insurance, and they net the insurance reimbursement out against the cost of the test and bill us for the difference. And so the question is, do we cash flow the laboratory, or does the laboratory cash flow the state? And we have two different models there, and where we are reimbursing for the cost of testing, we do not see the insurance reimbursement coming to the bottom line. We see the cost or the obligation to the state being much lower initially. And then with our K-12 schools and childcare testing, we are pretty much paying the full cost of that, assuming that with surveillance testing, it is not a medically necessary procedure and will not be reimbursed by insurance.
Okay, thank you. Senator Nelson and then Senator Rosen. We're going to have a lot of questions to work through. So Senator Nelson, to this slide, or did you have other general questions?
Thank you, Madam Chair. Actually, my question is back to my previous discussion with the commission. And if I can take that up now, if you like, or I can at the end of the session.
Let's try to stick to this slide, because I think Senator Rosen, so leave your hand up so I don't forget. Senator Rosen, to this slide.
Yes, thank you, Madam Chair. And Commissioner Kelly, so the 61.3 is just for the Mayo U of M insurance reimbursement for long-term care. And we will probably only receive insurance back on the community testing and not on the K-12. Is that correct?
Madam Chair and Senator Rosen, you're correct. The 61.3 million is insurance reimbursement for the Mayo and the U of M. We will not see insurance reimbursement for the community testing since we are reimbursing for costs. They are seeking insurance reimbursement to lower the state's costs through that process, and we are monitoring on a regular basis the testing that they're doing and their efforts to seek insurance reimbursement to ensure that our costs are as low as possible. And with the school testing, we are assuming no insurance reimbursement because it's surveillance testing.
Senator Rosen.
Thank you, Madam Chair. And Commissioner, then that number, the 61, will be tracked going forward in the budget.
Madam Chair and Senator Rosen, correct. And that number will change. It's an estimate based on experience that we've seen with Mayo and the U. And so it will change. It may go up, it may go down, but I don't know how confident Joshua is in that number.
Thank you, Commissioner. Thank you, Madam Chair.
Thank you. Senator Curran.
Thank you, Madam Chair and Commissioner. On the case investigation and intake, help me understand what that is again. That's not the contact tracing?
Madam Chair and Senator Curran, it does include some of the contact tracing. We have made significant changes to our approach to contact tracing since probably since a year ago, and especially since last summer. I'm not sure when it was that I was in front of this committee suggesting we needed hundreds of millions of dollars for it. The case investigation piece supports, so anytime there is somebody who tests positive for COVID-19, it is reported to the Department of Health, and we reach out to that individual. The first thing we need to do when the test results come in, the case intake part of it, is we review that result and make sure it hasn't been reported twice. We make sure we have all the information we need, and that is the case intake process. Then that goes to case investigation, where somebody actually reaches out to that individual to learn about the circumstances around their positive test and to see if they need advice or connection to healthcare or any other supportive services. The contact tracing piece comes in. We used it in a much more labor-intensive way very early on in the pandemic. Who might you have contracted the virus from, to understand how the virus was transmitting from person to person. As community transmission became the largest avenue of transmission in our pandemic, knowing who you may have contracted it from was harder and harder to determine, because people were getting it without knowing what environment they were in that may have resulted in it. So we pivoted our contact tracing. Initially, we thought we would be calling everyone who you may have spent time at a bar with, or time in the family cabin with, or wherever else. We pivoted to doing more online surveys, to doing an exposure notification app, to doing text messages, to asking people to providing individuals with the information that they could share with their contacts. So it became less informative to our pandemic control to do the contact tracing. And so we have the biggest and most valuable piece of that effort has been around the case investigation and the case intake work. And that's where we have invested a lot of our resources. But it is, at times we have had over 1,000 people doing that sort of work, especially when we were seeing 10,000 new cases a week, and sometimes 8,000 and 9,000 new cases a day.
Senator Coran.
Thank you, Madam Chair and Commissioners. So have we explored, what are we doing to further increase our effectiveness and reduce our costs? We've explored, and all of us on this committee are looking for options and alternatives. And there are companies that are producing applications that would appear to greatly enhance our capabilities to do contact tracing more effectively than anything we're doing with the human resource today, or at least reduce it by tenfold, I believe. And also offering different services, so we could have, through that process of a positive test and contact tracing, they also have built-in scheduling for vaccinations and notification and other health, many other value-added services. And from the looks of it, it's only be a few $1 million a year from a subscription perspective. Have we explored those? And if not, when will we be exploring those in the very near future, so we can get the contact tracing costs reduced and tie in all of the vaccination schedules and get everybody in the queue, so they're ready, they can do notification, they can provide everything for a couple $1 million a year. We would like to see that explored.
Commissioner Kelly, I know you and I spoke in May about getting technology off the shelf that supports our contact tracing. So Senator Coran's following up. Where are we at?
Madam Chair and Senator Coran, we did pursue looking at an off-the-shelf product or custom-built product for the state to support our case investigation, case intake, contact tracing work. And we evaluated the products out there by 10, 11 different vendors. And in the end, it became apparent in evaluating what they could offer and understanding how it would integrate with our current database that we use for managing reportable diseases, and understanding the experience of other states who had worked with various vendors. We made the decision to augment our current systems and to provide smaller add-ons to it that would let us leverage some of the efficiencies you're talking about. So we now send text messages, something that we were not able to do before. We send automatic emails out when people provide their email address to us as well. we worked in partnership with Apple, I believe, to stand up our Minnesota exposure notification application as a way for people to use technology to understand the extent to which they have been exposed to COVID-19 in an environment where most transmission is community transmission and not from a specific interaction. And so we are continuing to evaluate and revisit our approaches so that we can find as many efficiencies as possible in addition for financial savings, but and in addition to that, just for the wear and tear on our staff and the hours that is being committed to this effort, that there aren't enough epidemiologists out there in the state of Minnesota to help us with this, and there are not enough epidemiologists in the country right now to help with this pandemic to fully staff it in that way.
Thank you. Senator Curran, anything further?
No, thank you. Thank you, Madam Chair. And I always, everything that is said, we always lean back to this home or custom built. And I get concerned that the decisions we made previously have limited us in the opportunities to truly purchase and go after a commercial off the shelf. We've all been presented with many options, right, as the vendors are trying to educate us. But there's, if there's a healthcare company or a personal health application that's doing all these things, I think it really seriously needs another look, especially when we're talking about combining all other health service benefits and moving into text messaging is not some rocket science. It should have been from the very beginning. All of these other applications would have not just text message emailing, but personal app notifications with more value-added information, and to tie that into scheduling of vaccinations would certainly seem like something we still need that would greatly reduce our costs and expand accessibility across the state. So thank you, Madam Chair and Commissioner.
Thank you. And something that I thought about it as I was thinking about technology. If we have people calling and trying to get questions answered versus an app on your phone, because nobody's calling at 10 o'clock at night, but maybe you have downtime, maybe you're a little more open to sharing information after you're done with the rest of your day. And so, yes, staff are exhausted. How can we help them? We just keep going over the same things over and over. I am not making any progress on this, but I thank Senator Curran for his question. Senator Rosen, and then we'll go on to the next slide and check in with Senator Nelson. Senator Rosen.
Thank you, Madam Chair, and I appreciate you allowing me to ask a few questions about the vault, which I'm ashamed to say I don't know that much about. I don't know much about how much they've received. Here it looks like it's over 200 million they'll be receiving. I'd like to have more information on their contracts, how long that contract extends, how much funding we've already given to them. And if that's something that the commissioner can answer now, or if she would like to send something to us. But, there's a lot of money that has been expended to this particular entity. And I just want to would like to have a second set of eyes with this committee to make sure that we are not locked into something ongoing also. So Commissioner, could you please send us some information?
Commissioner Kelly, and just for the committee's benefit, there's a contract that was signed this fall. I believe it was effective date October 21st, 2020. I know Ms. Fisher found it for me, and MDH sent it to staff, so that can be forwarded. I want us to be a little cautious. Vault Health is a national entity. Vault Medical Services is what we have contracted with, along with Infinity Biologic. They own the laboratory equipment. So we talk about Vault, and I just want to make sure as people are Googling, Vault Health is a larger entity. Our contract is with Vault Medical Services. I don't understand that relationship. I hope there's somebody out there who can do that exploring. But Commissioner Kelly, could you comment as to when we will see the contracts for this money?
Madam Chair, Senator Rosen, we're happy to get that to you. I believe that it shouldn't take long. I know I've already sent it to you, Senator Benson, and so we can get that to Senator Rosen in the next day or two. I'm assuming Lisa's on the line here and she can make that happen.
And Commissioner Kelly, I apologize, but I don't recall seeing an addendum to the lab processing contract that covers these amounts. So were these amounts incorporated into the October 21st contract?
Madam Chair, I'm not sure the status at this
Okay,
point.
thank you.
Yeah.
Thank you. Senator Nelson, to this slide, or do you want to reserve for the end?
My questions are really about a previous slide, so I'll reserve those questions till the end.
Let's keep moving to the next slide, which is a retrospective, I believe. So we just finished looking at January through December, and we are down to our last 10 minutes. So $325 million for January through December of this year. Mr. Bunker, I'm going to ask you to accelerate to the next slide. I know you probably weren't done here, but let's look at the next slide.
Thank you, Madam Chair. Lisa, next slide, please. The next slide is our retrospective that is looking from March through December of 2020. I'm sorry. You will see the areas in many ways organized by the categories that we spoke of a couple of hearings ago, but then horizontally across the top, you see all of the funds and sources that were included in the response to date. And so you see the total right now that we're tracking is right in the neighborhood of $670 million. Moving to the right, the CRF amount, a total of 274. COVID-19 Minnesota, I believe someone was speaking about a $200 million amount. The Healthcare Response Fund, you will see those lining up with the very bottom row of this chart, which is the Healthcare Response Grants. The Public Health Emergency Response amounts, which include the short-term emergency grants, and it was up to $25 million worth of spending. These again are from general fund moved over. We also had federal non-coronavirus relief funds that were associated with the response. The majority of these monies were from federal flexibility under existing CDC awards, primarily, where the work plans for those were extended to allow work on the pandemic itself. And so you see right around $9 million. General fund would be those operating funds from the agency that didn't have riders or specific definitions associated with it. Indirect amounts, that was from our agency's indirect budget with indirect earnings on federal awards themselves that were committed toward the response. And so you'd see persons, whether it be in the executive office, HR, communications, those types of costs, many of them would show up in that indirect line. And then you see a column with an unfortunate fund name of gift at the top. That actually was a gift from a citizen toward the response of $1 million toward testing effort that happened toward the end of last calendar year. And that amount was used for tests within the public health lab. On my screen, I'm seeing a lot of faces over that column, but at the bottom, you see $1 million amount. And so it was $1 million of a gift that was used toward the effort itself. So this is just a summary of activity that happened within the last calendar year. I don't know if there are any questions on this because of time, Madam Chair.
I think because of time, we're just this is good information for the committee. Senator Rosen wanted to know we should write that person a thank you note. So I want to be very clear. We are grateful, and I was not aware of the $1 million gift. And so deep gratitude to the generosity of Minnesotans, not just in this way, but in all the other ways through the pandemic. Senator Nelson, let's wrap up with your questions.
Oh, thank you, Madam Chair. And Commissioner Kelly, my mind is still swirling around this idea of using our existing infrastructure and who makes that decision. And so can you just who makes that decision about whether limited vaccines go to new type of systems, repair new programs, new ways to get people vaccinated, and what go to those existing providers, pharmacists, and such. And so, can you just give me an idea on what percent of vaccines have already gone out the door to those who already have those relationships with Minnesotans, and what percent has gone to maybe like these MaxVax sites or these test pilot sites? And then again, who makes that decision on how to distribute those vaccine allocations?
Commissioner Kelly?
Madam Chair, I would need to get back to you on the percent that has gone to our traditional partners versus the doses being used at the state vaccination sites. I would, since December, I don't know, 14th sticks in my mind when we started getting vaccine. I think the vast majority has gone to our traditional vaccination partners. We started with just a few partners, like maybe 100, because the first doses were Pfizer, and they have very specific storage requirements that not everyone could meet. And so we, at that point in time, had what we call the hub and spoke system, where we shipped doses to someone who had the deep cold freezer. And then we pushed it out on the day of administration. Now with more time for people to get the storage capacity they may need for Pfizer, but also with the Moderna vaccine that does not require that deep freeze, we have more providers who have registered. So we're up at about, I think, 1,600 providers now who have registered with us to receive vaccine. And we don't have sufficient vaccine to give every provider the doses that they'd like to have. And so we have used randomization. We look at who has gotten them in the past and who should be getting them. And so it's a complicated balancing act of competing needs versus limited supply. And we make that decision within the Department of Health.
Thank you, Madam Chair. Thank you, Commissioner
Senator
Kelly.
Nelson.
Thank you. I'll look forward to that information. The reason I ask is because, one, we know that those traditional partners, as you say, know best how to allocate those vaccines according to need. And the lottery system or the first come, first serve system just did not do that. And I'm very concerned about getting vaccines first into those who obviously are in those highest priority categories. And also some concern about, are we developing infrastructure that we already have existing infrastructure for? Although I don't think that's the case. But I did do the math, and it looks like, according to the numbers you gave us, that about 1.6 million vaccines through our traditional partners could be could be successfully administered each month, if I understood your previous comments correctly. So,
Commissioner Kelly, and we need to wrap this up. Senator Abler does have further comments, but one of the challenges I've had is a lack of transparency, and I tried to find it again before the hearing, where vaccines are going. We had a big headline that 35,000 went to senior 65 and over, and my first thought was, well, where'd the rest of the vaccines go then if they weren't going to seniors? So we don't know where all the vaccines are going. And so some transparency is in order, I think, and not just a cumulative, but some are being diverted to these mass vaccination sites. How many is that on a public dashboard for the public to see? These vaccines are a state resource. They're not, they are under the stewardship of MDH. They are not part of a hide the ball game. And I know that's not your intention. And I know you have a lot of responsibility, but clarity, if not certainty, is what we need. So if you can just be clear where the vaccines are going, at least we'll have that question answered. Senator Abler.
Thanks, Madam Chair. And I vote for clarity, I guess. This is certainly a finance committee, Madam Chair. If people ever wonder, here's the math. My question is just a little different, and just I've had a bunch of people wondering about immunizations for people with disabilities.
Yeah.
And just in real short, I understand that the people in institutions and group homes are just about ready to get it. But what about people living independently? So could you just comment about that? And whatever they want to say is helpful to me, Madam Chair, so I can answer my constituents. This is actually the most common question lately.
And Senator Abler, I didn't realize that Dr. Erzman was leaving. She probably would be better suited to answer, but Commissioner Kelly, we're going to put you on
very
that.
informed, Madam Chair. I think Ms. Kelly could give us a fine answer. So thanks.
I think Commissioner Kelly, we're going to put you on the hot seat in the equity view. Where do people with disabilities fit in your equity calculation?
Madam Chair and Senator Abler, the plan for allocating the vaccine was, the goal of the plan was to vaccinate for impact. And in looking at the allocation committee at the federal level and at the state level, we took in the federal guidance and made some adjustments to it. But the strategy was to vaccinate for impact and to protect our most vulnerable first. And so there were categories of prioritization, 1A with phase 1A, where we had priority 1, 2, and 3. And the first people to get vaccine were those who were most at risk for contracting it, people who worked in the hospitals and on the COVID floors, people who lived in congregate settings of first long-term care and then assisted living. And so we are still working through that phase 1A population. And at the same time, we have opened up eligibility to components of phase 1B, which includes people over the age of 65 and people starting to look at workforce sectors, people who are in the education sector. People who are over the age of 65 and have a disability would certainly be eligible right now for a vaccine. People who are under the age of 65 and have a disability are kind of in that category of if they have an underlying health condition, then it would be when we open up the eligibility to people between the ages of either 16 or 18 and 64 with comorbidities. And that clearly needs more clarification, and we're working on that, but that's what our allocation phases try to address.
Thank you, Madam Chair, and just being very brief. And just particularly the family of Downs families are just very concerned. Their mortality is in the low 60s, I think. And so I didn't ask the question to be critical. I just wanted to ask the question. And there's a long line, but I think that these individuals are not the same as just some random 20-year-old who's going to be in line with them. So thank you, Madam Chair. Appreciate getting asked.
Thank you. And Senator Abler, that was on my list as well. Well, I've sent emails on it and we've asked it in committee. Eventually we're going to get an answer. Senator Wicklund.
I just want to make a comment that I would also point out that the vaccine website does have a whole dashboard that does show doses administered, percentage of doses administered by site. So it does have a pretty extensive list of the sites that are receiving the vaccines and the numbers. So I think that the department has been working on making more and more data transparent and available to the public so they can see, who is getting doses and are they meeting the goals to get those doses in people as quickly as possible. So I think there's a lot of information that is provided already, and I know that they have a continuous improvement process to keep adding more to that data.
Thank you, Senator Wicklund, and that is true, and I have observed that. But when we're getting a limited amount each month, each week, actually, knowing how that's being divided is not something that I understand. You know, if we get 65,000 doses and 30,000 of them are going to hospital systems, where are the rest of them going? And so that was my question. It's a week-to-week decision. The department is making it. I don't know who at the department or when they make it or how. And so what you say is absolutely true. I perhaps didn't ask the question as gracefully as I could have. Senator Nelson and Senator Abler, I see hands up.
Oh, Madam Chair, just people who don't know how to put their hands down. Thanks a lot.
Okay, thank you. And with that, Commissioner Kelly, this team could have spent a lot more time on these slides. You were generous with your time. I appreciate you and Mr. Bunker preparing this. Senator Rosen and I have now seen this. Hopefully it shortens some time in the LAC. We have to do that presentation. I appreciate your work. We would like to see those contracts. And with that, members, seeing no further hands, we are adjourned.